Welcome everyone. This is Dr. Jaitly on your favorite website, MuniMeterHealth.com, which is dedicated to teaching you about the human heart and its illnesses. Essentially, this is a medical education website, just so that you know. It's been shown on 2 social media channels. And of course, it's educating for human heart awareness to the patient educations as well. However, if you're experiencing an emergency, please see a doctor right away, go to the nearest hospital, or dial 911 to call for an ambulance. Without any further ado, I'd like to delve into the subject matter today. The subject today we are going to be talking about is cardiovascular effects of hyperthyroidism. So when the thyroid is rather active, what are the effects? And it's called hyperthyroid. We go by this sign here. So the diagnosis, remember, for a hyperthyroidism is very, very key and very easy rather. So if you have a profoundly low TSH, almost sometimes undetectable, and of course T4 and T3 are high. So highly sensitive TSH, as some of the labs are doing it for the past several years now. So these are the 2 ways to diagnose, except when it's primary hyperthyroidism, then of course the TSH will be high, and that'll produce the T4 and T3. So that's how you diagnose that part, when the TSH is being produced by the primarily by the pituitary, etc. So that's where the primary thyroidism comes in. Having diagnosed the hyperthyroidism, what are the clinical features now? The clinical features are mainly patients will be having an exercise intolerance. So that exercise intolerance primarily because of the respiratory muscles as well as for the skeletal muscles, they tend to be weaker, and there has been some kind of a myopathy that has been defined in these patients, just so that we know. Angina-like symptoms will be present. This is even though they do not have necessarily coronary artery disease, but angina, more of myocardial ischemia type of, when they walk, when they run, when they go up the hills, they'll have chest pain. So this is exertional chest pain, if you will, and that is typical of some of these patients with showing cardiovascular effects with hyperthyroidism. You will experience some of these patients will have pedal edema, and that's related because of the volume retention again, and we'll go to these signs later, but primarily we have to understand what the symptom presentations are. Congestive heart failure like symptoms will be present. Patients will be markedly dyspneic, and many times they will have, as I said, exercise intolerance, and they'll experience some palpitations, and palpitations normally are related to arrhythmia. So these are some of your clinical features. Now, why are these symptoms happening? Well, primarily because of this, as I said, is because of some myopathy that is being defined and looked into now still more in detail with the skeletal and the respiratory intercostal muscles involved. Angina, as I said, is because of the heart rate that's being at rest is also increased. It's at rest sometimes between 90 to 110, but during sleep it may be still in 90, which is very, very high. And when you get to the exercise level, there is an exercise exaggeration, if you will. And so in other words, there is an increased response during exercise. Like normally somebody who is exercising will get the heart rate by 10 or 20% per stage of the Bruce protocol, but here it could be going 20 to 40% higher. So in other words, they get tired very easily. Obviously they have an intolerance from that, but they also get short of breath, etc. So some of these patients have these problems. Now, blood pressure may be also high. Systolic blood pressure chiefly will be high, and the diastolic blood pressure tends to be low. Now, the diastolic pressure tends to be low because of the peripheral vascular resistance, which is low. And the systolic pressures are high primarily because of the heart rate being high and the force of contraction being high. So the inotropy is present as well in these patients. So there is an increased inotropy, which will later on translate to the ejection fractions being high as well. So just so that you know, these are some of your pathophysiologies, and the dyspnea primarily results because of 2 reasons. One, there is increased volume retention. I'm just giving you explanations for all these symptoms because that's so important. Volume retention is because of the increased fluids, which we'll talk about in a second. And the second part of dyspnea is because of pulmonary vascular resistance being high. Remember, there are two things. Systemic vascular resistance is low, but the pulmonary vascular resistance is high. Sometimes, one of the things I always tell my interns and residents and fellows during their time when I was a professor and teaching, I would say that if somebody presents with unexplained pulmonary vascular resistance or pulmonary hypertension, look for T4 and T3. You might be able to diagnose hyperthyroidism from pulmonary hypertension as well. Okay, so having defined that, now let's understand what the pathophysiology can be. Now, thyroid looks more like an H-shaped organ, if you will, and this is the middle lobe, and these are the two, or the isthmus we call it, and these are the two lobes of the thyroid. The liver will show like this here, because obviously all the, pretty much all your, we can show the heart obviously in this fashion, and then there are skeletal muscles, and we'll show the arteries here in the skeletal muscles. And we can show maybe perhaps the kidneys here, if you will, because these are the various organs that could be involved here in the pathophysiology. So if you were to explain the pathophysiology, this is what I would suggest. This is what is happening actually. So T4 and T3, when they go to the heart, they will increase the heart rate. As simple as that. They will increase the positive ionotropy, so therefore the blood pressure will be high, chiefly the systolic blood pressure. Now, very importantly, T3 goes to T4 and T3, they also go to the liver, and as they get metabolized in the liver, primarily it's the T3 activation that occurs, which will activate the RAS system in the kidneys. So renin, angiotensin, aldosterone mechanisms, they go higher, and that leads to volume retention. So the volume retention occurs primarily because of the activation of the RAS system here. And so you have an increased heart rate, you have an increased blood pressure and volume retention, so that leads to hypertension, and then it also leads to increased cardiac output. Very interesting. Now, very interestingly also, the diastolic blood pressure tends to be low, and the reason the diastolic blood pressure or the afterload reduction occurs is primarily because of the tissue thermogenesis. So there is tissue thermogenesis present because of the T4 and T3, and as a result there is a systemic vascular resistance goes down. So systemic vascular resistance goes down, so as a result you have a blood pressure, diastolic blood pressure chiefly going down. So in a nutshell, you'll see these are your parameters that are really happening, and this is how the pathophysiology works. So you have tissue thermogenesis leading to systemic vascular resistance reduction. You have an increased heart rate and increased blood pressure leading to cardiac output being increased. And you have an activation of the RAS system, which is also causing the volume retention. So most of these patients will have high cardiac output failures, we call it. So when they progress to have heart failure, it'll be a high output failure, not a low output failure. The other reasons where you have high output failure is like in AV fistula. Sometimes you see it in FEOs, and also sometimes people see it in even in acquired AV fistulas, like in the setting of renal dialysis. So they all have high cardiac output failures. Anemia, for instance, or thyrotoxicosis we talk about. Of course, this is hyperthyroidism anyway. So having defined the pathophysiology, we understood now, obviously, the systemic vascular resistance, high, pulmonary resistance, low, heart rate is high, blood pressure is high, cardiac output is very high, and all of these are the various, and volume retention is present, so that's also high. So all of these are the major hemodynamics, if you will, if you were to call the pathophysiology, and the hemodynamics, we just summed that up also here for you. So having defined that, now let's understand what are the effects. The effects obviously will be blood pressure, which is hypertension, and that needs to be treated. Primarily, you should treat that with beta blockers, and we'll go to that in a second, because that's very helpful. And arrhythmias. Arrhythmias can arise in these patients, and arrhythmias are primarily because of increased sensitivity because of the sympathetic tone and a decreased sensitivity to the parasympathetic tone. So invariably it is sinus tachycardia, more often than not it's SVT, and then atrial fibrillation should not be forgotten. Atrial fibrillation, and by the way, all these three can reverse if you treat the thyroid. So reversible by anti-thyroid therapy. If you give anti-thyroid therapy, all of these can be reversed very, very easily. So just so that you know. So hypertension, arrhythmias, and then congestive heart failure. Very important, but that's a high output failure. But it should be treated the same way as we would treat the others, except that here you want to use beta blockers very early on, and it's very safe to use them. One, primarily you can improve the heart rate and the forcibility that's the patient is experiencing. And two, even though the ejection fractions are high, but beta blockers are wonderful in these patients, and it'll control the sinus tachycardia, the oxygen consumption, the angina will disappear, the SVTs and the atrial fibrillation, the rates will be much better controlled, the arrhythmia proneness will decrease. But if somebody has atrial fibrillation, then you have to, again, treat with antithyroid therapy. And as I said, in 2 to 3 months, you should be able to put these patients back into normal sinus rhythm. And once they go into normal sinus rhythm, then they stay in normal sinus rhythm as long as the thyroid status is euthyroid. So in a nutshell, you've learned the cardiovascular effects of hyperthyroidism in these patients, and stay tuned for more as coming up. But again, as I said, if it's an emergency, you should immediately consult your doctor, go to the nearest hospital, and of course, call for an ambulance and dial 911, and this way you get to the hospital rather quick. Primarily, we are dedicated this website, MuniMeterHealth.com, only for clinical education to our medical fraternity, my interns, residents, and fellows across the globe. And of course, my colleagues like me and the internists who are practicing medicine. It's a good brush up to before you go and see a case. Obviously, in a matter of a few minutes, you'll brush up your skills. And people who are taking the boards and exams, again, this is more of a supplemental information that we are offering. Again, obviously, it's not a text, but at the same time, it's a supplemental information that they can supplement to their primary text that has been advised in their universities. So stay tuned for more video vignettes as they're coming soon your way. Okay, thanks again for watching. So long. This is MuniMeterHealth.